Did you know, according to AmSpa, nearly 1 in 5 med spas open today launched in just the last year? In a market that crowded, standing out isn't optional. It's everything.
Moxie is your edge. It's the only all-in-one growth and operating system built exclusively for med spas. More than 400 practices trust Moxie to help them launch stronger, scale faster, and run smarter with less guesswork and more profit.
You get expert-backed coaching and compliance done for you. High ROI marketing that predictably and repeatedly brings in your ideal patients. Software built for aesthetics with built-in tools for clinical, compliance, and revenue. And exclusive VIP savings, up to 55% off pharma, products, and devices.
Whether you're just starting out or scaling to 7 figures, Moxie gives you the clarity, support, and systems to grow boldly and sustainably. We're excited to share that Fill Me In listeners get $500 off their launch fee by visiting www.joinmoxie.com/fillmein or clicking the link in our show notes.
All right, guys, welcome back to another episode of the Fill Me In podcast. I'm Injector Jon.
And I'm Aesthetic Nurse Nicole.
And we are going to be talking about high-risk danger zones for injecting today, which is a new one. We talked about it a little bit.
Yeah,
in
I feel like we've done like complication management and stuff, but I feel like we've never really focused on high-risk areas.
Yeah.
We both definitely treat some considerably high-risk areas.
We do. And like, I treat an area that I feel like is more risky than
the area I treat.
That you treat, and I won't treat your area.
And I will treat your area.
I know, which honestly, like, Nicole, just do it. But like, I don't know. I know.
So we're gonna dive into that today.
We're gonna dive into that. I know it like won't make sense, but I think it will make sense for those listening. Maybe not. Who knows?
Yeah. I think this one will be more for our injectors, but
yeah. Well, it's so funny too because I feel like obviously we're Allergan trainers, and like when we are at trainings, we can't do off-label areas, right? So so many people inject the Piriform, but like we can't in trainings because it's off-label,
right?
Right.
Yep. There's so many questions that get asked that we
so
can't.
Many questions.
Yep.
Yeah,
it's tough, but that's why this episode will be good.
It'll be so good.
Yeah, we can talk about all those things, and then when that happens again, we can be like, please refer to episode whatever of the Fill Me In pod.
So, Nicole, like, what would you identify or describe as a high-risk area?
So high-risk areas are areas that are more likely to have complications. So like a vascular occlusion, which can cause tissue necrosis, which would be tissue death, blindness, things of that nature. A lot of the areas that we treat on a day-to-day basis, it can happen. It's just more low risk. Our highest risk areas are going to be like your glabella region, your forehead, nose, laugh lines. That's what I would consider high risk. I mean, the chin, technically, those vessels are so small. I guess they are a little bit easier to occlude, but I would say your highest risk areas are going to be like forehead, glabella, nose.
And you'd think almost temple, but it's really not actually.
Yeah.
It's like on the lower, like right on the spectrum for high risk.
I think definitely it should be considered high risk because of the anatomy in that area. Because God forbid, if you hit that temporal artery, you're going to have a major issue. But I feel like now with the training and, basically it was FDA approved for use in that area. When you have an area like that, you get more training, more research on it. So you feel a little bit safer treating it, where other areas like the nose and forehead, they're not approved areas. So you don't have that research or
temple's actually like the 5th on the list actually of like high risk areas, but basically,
and I think too it's because probably too it's easier because it's only 2 anatomical. You have that rather than the nose is so many small little vessels. Same thing with like the glabella and the forehead.
And when we say high risk, like meaning for like vascular compromise and stuff, it's just because there's underlying vasculature there, like an artery or something. So you just have to make sure that you're practicing like safer techniques, right? You're aspirating. Even if you're at bone, always aspirate. Honestly, if you're using a cannula and you're in a danger zone, aspirate. You want to sleep at night. and you want to make sure that your patients are safe at all times.
And
right? And
what does it take? Like an extra 10 seconds to aspirate?
It does.
Like
Just
not
do
even.
it.
Yeah.
Yeah. And it will save your day. If you have like a 20 to 25 patient day, something like that happens, you're going to have to cancel your next 5 patients, if not maybe your whole day, just to take care of that patient.
Exactly.
Yeah. But the area that I actually treat, which is high risk, is the glabella for filler, which I think all of us would understand this. Like when patients come in and they sometimes wait too long to get Botox, and they've already had this like deep crevice in their 11 or in their glabella area. You know, Botox will only do so much. It'll help not make it deeper. It might soften it a little bit over time, but sometimes people still see, like, especially when they turn their head, like this deep crevice, and it just bothers them. Or they'll have that patient say the Botox isn't working. It's just not working.
It's not the
line's still there.
Botox.
And you're like, Botox isn't a wrinkle eraser, right? You know, it's the Botox is doing its job. You can't furrow your brow or make an angry face. But I'll do filler there. But what I do is I use a cannula, and I usually make a little poke about literally the center of the forehead, halfway through. And I'll make that little port, and then I'll use a 25 gauge, 1.5 inch cannula. And I use Juvederm velour there just because velour is so versatile. It draws less water. It feels honestly like this area. It's very, very soft, which is nice. But you have the supratrochlear artery and you have the supraorbital artery that's there. And it's a higher risk area. There's a lot of little arteries that stem off of those arteries, right? So obviously it is higher risk. If you're doing that area, you should be more experienced, I would say, and definitely have done cadavers and, you know, just
have a true understanding of where those vessels lie. Yeah. I actually, so when you said forehead, I thought you meant how people are treating the dips of the forehead down.
Yes.
So some people are actually placing filler right along the forehead to kind of round it out. It's huge. And I think like Korea and places like that.
In Asia. Yeah.
Yeah. So like, I don't do that obviously, but I will treat the 11 lines. But I do velour or skin weave actually. And I put it into a BD syringe. So like an insulin syringe, and I very, very superficial, like almost like the Fern technique, hit right along each line just to support. So like basically I pinch the skin. Look at that. We can really see it on me today.
Oh my gosh. You cracked me up.
I pinch the skin and I see where it's folding, and then I'll go right along and drop it. And then as I pinch, make sure that it supports the tissue. But my thing there is if I'm superficial, I don't feel like I'm deep enough to be penetrating an artery there. But again, technique, advanced training, because you may think you're superficial, but you might not be superficial.
Yeah.
You know?
Oh, for sure.
So
it makes like such a big difference though. I will say, like if you end up, you know, doing glabella filler there, definitely use, I mean, at least for me, I use a cannula. I feel safer. I'm aspirating for 5 seconds, even with it. I always say like in crevices like that, and also like even in the labial mental crease, right down here underneath, I feel like vessels love a crevice, and they'll sometimes hide there. So sometimes, like, you know, if you're listening in and you're an injector, just make sure you're extra cautious in little crevices, because that's where sometimes vessels lie.
Yeah.
And you can run into some issues. So just make sure that you aspirate. There was one patient that I was doing their 11 filler, and I was injecting. I went right down, and I hadn't even aspirated yet, but I was going down, being very gentle, and all of a sudden blood just shot right up. And I was like, oh, it was a butthole clench.
Yep.
And,
for sure.
You know, and I'm like, you know, and then I'm just
like, is everything okay? You're like, yeah, everything's fine.
Yes. And of course I'm talking to the patient. They're great. I'm fine. I was just like, okay, perfect. Like pull it out. We hold pressure. And it's so strange. Patient didn't bruise. Nothing happened. Wow. I went back, changed my position, and I was okay. Yeah. But it definitely scares you. But, you know, especially if the blood is just rushing up a syringe like that, you know, you're in an artery just because that pressure.
When you know, and that has happened to me in a temple before. So that is actually why I don't do a lot of cannula in the temple anymore.
I don't either. I do needle to bone.
Yeah, I'm like all needle to bone, which again, advanced technique, definitely need that experience there. But same thing. And it was the last pass. I had like 0.1 of the filler left. And this was when I usually do velour or voluma here. If I'm doing a cannula, I usually do velour, or I'll dilute voluma, which is off label.
Yeah.
but I had like 0.1 of it left, and I was like, oh, there's like a little divot. I just want to hit it. I go back in, and I hit a little like resistance. So I gave a little push, and my syringe just started filling with blood. Like I didn't even have to aspirate. It just started filling. And again, it was a cannula. It was a 23 gauge cannula. So yeah, when you're in a vessel, you'll know.
You'll know. Yeah.
Yep.
Yep.
But the area that I treat that Jon does not treat, and actually there is a lot of controversy around this, and there is a viral video right now that I'll see if Joey can throw in here for you guys about it, is the nose filler.
What is going on with this nose? She had a non-surgical rhinoplasty 3 days ago, and now it's red, hot, swollen, and painful. This is an infection. This could have gone extremely badly. This is an especially risky complication because it's in the so-called danger triangle of the face. Infections of this area can result in cavernous sinus thrombosis and death. So this must be taken extremely seriously.
And a lot of the times, either it's people that have a hump, or if you want to lift the tip a little bit more, or I do it in people with, similar to how, if you complain about the glabellar lines not going away with Botox, people that scrunch and have this horizontal line, a lot of the time it's because they're lacking support in the bridge of the nose. So I'll go down to bone and I'll pop some filler there. Same thing. I never do more than 0.3 to 0.4 in a session. I always separate my nose fillers into 2 sessions because the more you do, the more chance you have of compression. And a compression, injury is basically when you put a lot of filler and it's sitting on a vessel. So it's basically blocking the flow. So it's not a true occlusion, but it is because it's occluding that blood flow without being in the vessel. But anywho, I put it into BD syringes again. The insulin syringes and me are best friends. I use them for like all my high risk areas too, just because I feel like sorry, I just dropped my shoe. I feel like you are a little bit more precise with them, and you can also do very small amounts of product. So like 0.3 of product in a big syringe doesn't seem like a lot, but when you put it in BD syringes, you have like 6 BD syringes to work with,
Yes.
So I always aspirate in the nose too. Always. And I start in the bridge. So technically the bridge is going to be your safest place in the nose because those arteries should be be traveling on each side.
Right here too, honestly, I will tell you. Here, I do cannula there.
Okay, yeah.
I'll make a poke here and I'll just come down to there. Where I'm uncomfortable, and I think a lot of people are, it's from that hump down where I just get really nervous, and I'd rather them go to someone like you who does it more frequently.
All the time, And I think, again, I started with a plastic surgeon and he taught me, and I just feel like it's how you're trained, if you've never done it before, of course you're going to be terrified, but I will say this is where I do majority of the product. And then from here down is very, very small amounts. I'll start up here on the bridge, and then I'll come to the tip and I'll do probably about 0.05. So less than 0.1. Right at the tip, I enter from the bottom of the tip and I come up in, I drop 0.05, and then I come out, and then I'll do very tiny, like little aliquots if I need to, kind of tracing up onto the bridge.
Got it.
Again, more superficial.
You're saying central.
Central, always central. Yeah, I don't do any. There's like one patient that she had a rhinoplasty. Now that's something I want to touch on too. If you've had any kind of surgical procedure on the nose, you're not technically a candidate for nose filler because it's going to change how the vascularity is, and it's already so intertwined there. If you've had surgery, who knows what it looks like under there?
Change the anatomy. It's like getting a facelift. It's like when you do filler or Sculptra on someone who's got a facelift, like you just got to be careful.
Exactly. You just have to be careful. So I have a patient that has like a surgical like divot here, and I'll do, again, very small superficial little blebs kind of right through there. But I never, like I said, put more than like 0.3 to 0.4 in one sitting in a nose, and majority of that is going to be on the bridge.
Good to know.
Yep. But, that's cadavers and all of that. And it's just, again, how I was trained. And if you're not trained in it, I would not suggest trying it, Yeah.
We talked a little about Moxie earlier, but let's go deeper into one part of their system that really moves the needle: marketing. For many med spa owners, marketing feels like one big unknown. How do you get more patients in the door and keep them coming back? Where should you invest your budget to actually see results?
Moxie has the answer. They've analyzed millions of data points across 400 plus med spas to build a proven system that delivers predictable, repeatable growth. It includes high converting ad campaigns with 3 times ROI in month 1, up to 8 times in year 1. Event playbacks that can generate $10,000 and more in a single night. a library of done-for-you, scroll-stopping social content ready to post, local SEO to rank #1 in your area, and so much more.
Here's the kicker. It's all included with Moxie. No agency fees, no guesswork, only the ad spend you choose to allocate, with every dollar going directly to your campaigns. Meanwhile, external agencies charge $1,000 per month or more just to manage your ads before you've even spent a dollar on the ads themselves.
At the end of the day, you set the pace. Whether you want to start slowly or scale fast, Moxie gives you the strategy, tools, and expertise to grow your way. Visit www.joinmoxie.com/fillmein to get your personalized growth plan and $500 off your onboarding fee with Moxie.
Hey guys, just popping in to remind you to like, subscribe, and hit the bell for notifications. Also, don't forget to follow us on Instagram, Injector Jon and Aesthetic Nurse Nicole. Thank you so much for watching. And if you have any questions, leave it in the comment section. Another like higher risk area, which is Piriform, but I freaking love Piriform.
Oh my God,
who
it makes
doesn't love Piriform?
such a difference.
Makes such a
makes
difference.
such a difference.
With
So
the mid face, when you're treating the cheek, it's just such a difference.
Explain to the people what the Piriform area is.
The Piriform aperture is literally if you draw a triangle from your nair over to your fold, usually where that crease is, or you smile. So you like when you smile, you draw a little line, and then it forms a triangle, and you draw it up. Right to the corner of the nose. You do a little injection to bone, so to the piriform to bone there, and basically that is the deepest part of the nasolabial fold. Right, you start like the oral commissure, kind of adjacent to it. You follow that nasolabial fold up to the corner of the nose. That's literally where the piriform is, and that's where it's deepest, and that's where it accentuates that nasolabial fold. So before even treating or filling a nasolabial fold, I know you, Nicole, too, you treat the piriform aperture, and then I'll go up into the anterior medial cheek, and I'll follow the cheek along, and it makes such a huge difference in the mid face.
Yeah.
And a lot of times when you treat the piriform to bone, you don't even have to treat the nasolabial fold, right? It lifts it. Sometimes you do, and I'll do like an injection kind of midway through the nasolabial fold, and I'll do cannula, and I'll butt my cannula.
It.
Oh yeah, and I'll go right underneath that nose there.
Yep.
And it's really, really pretty.
Yeah. And you have to be careful there too. So it is high risk because of the fact that the facial artery kind of travels up. It basically enters into that area at that top 1/3, and then it travels up and turns into your angular artery. So you got to be careful there too. A lot of people do suggest doing ultrasound prior to. I don't personally. I have an ultrasound machine, but I just feel like for the amount of times that it would show something, you're already aspirating, you're down to bone. So you're as safe as you can be there to begin with. But if you have the time to use the ultrasound, it never hurts, obviously. And if you have the training, my ultrasound, I really use for more of dissolving or like emergency situations,
Right.
But yeah, the Piriform, it's a great injection because actually what happens too over time is we lose bone and everything starts to kind of sink this way. And that's why we get kind of wide through here too.
It's great to do, like I'll do in the right patient, do voluma there to bone. I will do velour to bone. It really just depends on your anatomy. If you're super thin, like, more gaunt, then you're going to use something softer. But if you have thicker skin, something like that you need to make more of a profound impact, then something like voluma is really beautiful. And then obviously, when you're doing nasolabial folds, I usually use velour, deeper folds like Ultra or Ultra Plus, sometimes I'll use. But yeah, I feel like we need to get away from like not treating the nasolabial fold in general. I feel like we went through this whole thing. Definitely, obviously treat the cause and do the piriform to bone first and do the cheek first.
Right.
And maybe address the under eye before treating the fold, because a lot of times when you're treating those areas, it does lift it and provide that support and lessen the appearance of the nasolabial fold. That should be your last resort to fill the nasolabial fold. How many times am I going to say that word? Oh my God.
No, I want to see if I can find a picture of me because I have obviously done my nasolabial folds with velour multiple times.
Yeah.
But yeah, here it is. Some people just need it because they have an etched line. Like,
oh yeah.
If I only did those lifting, injection points, that etched line would still be there. And of course, when you smile, there's still going to be something. I mean, this picture's from 10 years ago, but still my forehead looks the same now.
I can't with you. Oh my God. Also, honey, we got to Botox it.
No lips. Look at that.
Crazy.
I'm dissolving my lips next week.
Are you really? Starting fresh?
Starting fresh.
We love it.
Yeah, I'm excited.
Yeah,
but
that's great.
But yeah, like you said, I think that was social media fear mongering. Like, do not treat your laugh lines. Like, sometimes you really need to.
Sometimes
but like you said,
do.
start and like, yeah, if you only treat here, and especially on someone that's like gaunt or like really heavy in the face, if you only treat here, you are going to make them look so wide in the lower face.
The other thing I want to talk about is Sculptra a little bit because I love Sculptra in the Piriform and the cheek. Like, I do this technique, which I know a lot of injectors do, where I call it the sandwich method. So basically I'm placing filler to periosteum to bone. Sorry, not filler, Sculptra to periosteum to bone, which there's also fibroblast activity on bone. So it's really important to remember to place your Sculptra on bone as well and not just, subdermal or more superficial. So I'll do Piriform injection with Sculptra, and I'll do probably like 0.05 injections of Sculptra along the periosteum on the cheek, but then I'll also do more superficial subdermal injections of Sculptra as well, and it kind of sandwiches it. So you'll get collagen production more superficially, but then also deeper as well, and it provides such a nice support for the skin, and also for the skin to hold that filler better too.
Yeah, I was going to say too, like doing deep with that superficial, you're getting that glow, but then you're also getting that support to the tissue that it really genuinely needs. Where if you're only subdermal, you might not get that support.
Right. It's nice.
Yeah.
It's better. And it's long lasting. It lasts 2 to 3 years, which I love.
Yes.
I think Sculptra is a great alternative for patients too that are so filler obsessed, or they're like constantly chasing things.
Yep.
When they come back, say, no, we're going to do Sculptra today. It's going to give you what you're looking for. But if we keep filling, we're just going to end up too puffy.
You're going to look crazy.
Yeah.
Yeah. Sculptra is something we carry now because we brought Gab on. Gab's been doing Sculptra from like day one, but obviously me and Melissa never really dabbled in it. So that's something we now offer. And we have our PDGF training on July 1st. So
I'm so excited.
So excited.
I love that for you. It's just such a game changer.
Yeah.
Biostimulation along with filler. It's great.
Makes such a difference.
Especially when a harmonica comes. I'm excited.
Oh
for
my
that.
God, I know.
Another high risk area is tear troughs.
Yes.
So how do you do tear troughs, Nicole?
So I have a little bit of a different technique depending on the person. So on someone that I can truly see the groove and I feel like their ligament really isn't too tight, I will do a cannula. But if you have someone that has a really tight groove, you can't really like almost me, you can see today because I have no makeup on. Like, you see how my hollow kind of curves? Like someone that has a more straight down hollow, I feel more confident using a cannula. On someone like me, I put it into BD syringes. Sponsor me, insulin.
Yep.
Insulin syringes. But I put it into those small insulin BD syringes, and I will actually chase the ligament right at the like orbital rim. And that's a technique that I learned from Dr. Surik at his injection anatomy, that weekend course years ago. But it's the thought behind it is if you're placing the filler directly into the ligament, you're going to have no migration over time. If you're using a cannula and you're potentially in the muscle, every time they blink, every time they animate, it can potentially move that product around. And that's why we see that kind of like, I like to call it pooling, or like you see that
puffiness,
bulge.
Issues with lymphatic drainage.
Yeah. So if you're using small amounts and you're getting it targeted directly into the ligament, you technically will have better longevity. It'll just look better over time. So I would say a lot of the time I am doing that BD technique, unless it's a true, just like straight hollow that I can easily pop into.
Yeah, no, I feel the same way. I feel like I love doing under eye filler, but it's just finding that right candidate is so important. Like I feel like, especially in the younger patient, a lot of patients come in that are younger in their late 20s, 30s, and they're just not there for filler, or it's more dark circles or thin skin, or they have that more mature patient that just has thin, crepey skin that wants tightening. And those are great candidates for either PRP, PRF, Easy Gel, or PDGF,
right?
Which is wonderful to stimulate collagen, elastin, and to help tighten that skin. But I would say normally when I'm doing under eye filler, I'm using a cannula, right? I'm right between the ORL, or orbicularis retaining ligament, and that zygomatic cutaneous ligament, right? Which, and I'm down to bone, deeper injection, never superficial when I'm doing under eye filler with cannula. So I'm deeper in the tear trough, like I am with PDGF injections. For those of you that are asking and DMing me about the depth of PDGF, always deeper. And then like you, especially like in the outer, like lateral orbital rim, I will put Globella in a BD insulin syringe and I'll go to bone and I'll place little aliquots along that lateral orbital rim. Or like you said, even anterior, I'll go into that sweet spot where sometimes it's needed.
Yeah, you just need that little lift. Yeah. Yeah, and you said Globella. I always use Globella there. I don't put anything else in the under eye region.
Yeah, I used Restylane Classic, and nothing against Restylane Classic or Restylane Eye now. I think it's Eye.
Yeah, Eye Bright or something. I like
oh
maybe
God,
it is.
They're probably laughing at us, the Restylane people. But I like maybe. It's nothing against that product. I just prefer Globella.
Yeah, I do feel like when I use Restylane, I did get a little bit more tindling.
Okay.
And I don't know if that was just technique because I started using Restylane when I first started. So that might have just been user error.
Sure.
But with Globella, I feel like I just don't see that as much. I have done Skin Vive under the eyes quite a few times actually. And I do like that too. But I'm excited to start dabbling with the PDGF under the eye. I think I'm going to do mine first. Be my own guinea pig here. Let Melissa and Gab do it.
I mean, do you see mine?
Yeah.
I mean, I've only done one session. I need to do my second. That's
but they look incredible. And it still looks natural. Like that's the big thing, you know, like, and I feel like that's another thing too. Like patients will chase, like they want no hollow there. Like that's not normal. We have to have something there, you know?
And I find too, like with my patients that are older that have bags, but like crepiness, I find it doesn't cause more puffiness.
Good.
Especially when you inject deep. If you inject superficially, you could have a little bit of puffiness and you can cause some issues with lymphatics. So just make sure you're deeper with the PDGF.
Are you using cannula with the PDGF still? Okay. But just very deep in there.
Yep.
Like dragging on bone basically.
Yeah. Okay. Literally when I'm, once I hit bone, I change that direction. Yeah.
And just gliding right up.
On bone. Yeah. And you know, just glides right up.
Yep.
And then I'm fanning. I'm kind of going up, right up to here, coming back, fanning. Fanning. And sometimes if I'm able to come all the way over here.
Okay. Yep.
If not, just putting a 30 gauge needle on it and going right to bone and putting a couple droplets there.
Perfect.
But yeah, I just avoid the superficial because of the angiogenesis and the redness. But honestly, whatever. If you cause a little bit of it, you want it.
Yeah.
It's a little bit of downtime.
It's not a bad thing. Yeah.
I did it that way. I ended up just fine. So
yeah, you healed fine. It just took longer.
Just a little bit longer.
Yeah. But if you explain that in your consult and the potential of how long
and you gals have concealer. I don't.
Oh yeah, we're allowed to wear makeup. Well, you're allowed to. Technically,
I'm allowed to. I'm free will, but I don't want to. So that's just me.
You don't want to wear concealer. I don't blame you.
Yeah. Yep.
So you also mentioned the submental crease.
Yeah.
Definitely that mental crease area. I think I'd have to go back in my notes, but again, I love Dr. Surik's course. Like if any injectors out there, I feel like if you're like anywhere from like 1 to 3 years in, I think that's a really great course to go to because it's advanced enough. And you still don't know everything. I mean, obviously we're almost 8 years in. We don't know everything either, but I'm just saying it's definitely really good if you're in that like 1 to 3 year range. But his course, I learned so much in the cadaver aspect. And I think it's a crazy number. I think it's like 70% of something of people's inferior labial artery actually lays in that mental crease. Well, instead of that lower lip. So that's something where just switching to a cannula and popping in right next to the crease and just going right across, it's going to keep you and still aspirating because you can.
I feel like when I'm doing lips and I'm like, you know, I don't know, providing that support with my hand and I'm going whatever, I can sometimes feel that pulsation from the artery there. So no, I know what you mean.
Yeah. So that's why like, even with the cannula, always aspirate, you know, as long as you know how to take care of these things, your patients are always going to be okay. It's just, you know, it's just, there's ways to avoid it. And when it's happened to you, you learn those ways.
Right.
Yep. But that's another area. And then the submental arteries are kind of like a little bit off from the midline down here. And that's why too, when you're using needle, you want to be very careful there too, because again, not only can you pop into them, but you can also cause that compression too.
Yeah. Just aspirate and always when in doubt, aspirate.
Yeah. What would you say the biggest bolus is that you'll safely, you feel comfortable doing?
In the temple, I do 0.5 ml, which that is a protocol per Allergan.
Yes.
But I do 0.5 there. Piriform, no more than 0.3.
Okay. That's me too. Yep.
The chin, I've done 0.3.
Okay.
Sorry if that's too much. I know people usually say 0.2.
Yeah, mine's 0.2 in the chin, but
okay.
Yeah.
And just some people I'll
Yep.
do 0.3. Like today I had someone who I was watching the skin rise and it was like perfect and it was 0.3 and then I went over, it was 0.2, whatever.
Yeah. Sometimes too, I'll do like a 0.2 and then I'll do like a little Hershey kiss, like just keep injecting on my way out. Yeah.
Which that is more advanced, I will say. So make sure you know your anatomy and just, have Hylenex, God forbid.
Yep.
But I know a moving needle is a safe needle, they always say.
Yes.
Gonial angle mandible, I usually do 0.2s back there. The cheeks, 0.2s. And then when I go more lateral, 0.1.
Yep. That's how I am too. And sometimes like all the way back, it's like a 0.05, like not even a 0.1. Yeah. In the gonial angle, I'll actually do 0.3, 0.2, 0.2.
Okay.
Yeah.
Nice.
But yeah, my highest bolus is the temple.
Uh-huh.
Yeah.
Yeah. A lot of people are scared to inject the gonial angle or like that, the jawline or posterior mandible, just because first off, I know it's so hard to find that gonial angle sometimes. And like, you want to find just that right angle to pop it and give that nice, like sharp little angle there.
Yep.
But whenever I'm teaching jawline back there, I'll do like that three or four injections, back through here, like 0.2, 0.2 or 0.3, 0.2, 0.2, 0.2, and just follow the shape of the jaw. But then we'll find that little mandibular notch there and we'll mark that as the danger zone. We don't do needle to bone there. And then because people are always like, oh, we do that, but then there's like that little disconnect
you miss
here.
That, yep.
But you have to do cannula there.
Yep.
Yeah, just to harmonize it.
The reason we do cannula in that area is because if you think about how the facial artery comes up through that antegonial notch, it's deep.
Yeah.
So it's going to be laying on that bone. And some people,
really
my
will.
God, it's like some people have a notch that is like 2 inches deep.
Yes.
But so if you use a cannula and you say superficial and you
I'm
just
one of those
lay,
people.
are you? Yeah. Mine's so small. But if you stay superficial and lay it with a cannula, you're going to be so much safer because you're not going to be in the same plane as that artery. So that's why we do it that way. The bolus is in the back with needle and then switch to cannula.
But just saying, if something happens and you think that you cause a vascular occlusion at the angular artery, right? Or infra or supralegal, you can find that little notch and inject into it.
So that it flows.
So it flows right through and will dissolve that clot.
Because this is going to be the easiest part of that facial artery to find. And that facial artery is going to connect to all of those little branches.
Right.
Yep. And then remember too, Hylenex is permeable. So even if you can't find the artery, just flood the areas because it will make its way in. It will find its way there.
Exactly.
Now, unfortunately, if God forbid you have a patient that goes blind, which is more common if you're going to be treating the forehead and the nose areas, that is typically permanent, unfortunately. But the best things that you can do is like vigorous ocular massage.
Yeah.
So you really want to, it's like taking your thumb and you are like really pushing back and forth on that eye.
Yep.
And you want to be doing that for a good amount of time and always have a retina specialist that you can refer to. And if you don't, I would send them to like an ER and just make sure that they have an ophthalmologist or somebody on call that you can refer to. But yeah, unfortunately the vision is the hardest thing to treat. And if it does happen, you may not have resolution of that.
Yeah.
Yeah.
So I think like the biggest, obviously, like if you're listening or tuning in, the biggest takeaways with this, and we could talk about this like so much more. I feel like there's so many different patient situations.
Yeah.
Everyone's anatomy is so different.
Technically every area is a risky area. It's just that there's more areas that are higher risk, which is what we talked about today.
Exactly. Because of like the blindness and things like that. But basically quick action. So like just know the signs of a vascular occlusion, right?
Yes.
Always check cap refill. If you have any delayed cap refill, that's obviously a warning sign. If there's an area that's white or dusky, right? Like doesn't look like it's getting oxygen, then that's obviously a danger area.
Yep.
So just know how to recognize ischemia, which is a lack of oxygen to the area. So if there's any prolonged blanching, just start your Hylenex, stop injecting, evaluate your patient, apply heat, or do nitropase, or to have the patient take aspirin, and, start your own protocol. I know when Michelle Duran visited Syracuse, she is an injector and an allergen trainer out of, I think, Boston. Do you know her?
Yes, love her.
Oh my God. She has at her practice a code called Code Blanche.
Okay, love
which
that.
I think is so great. So she just goes, I have a Code Blanche, and she'll say, and everybody just stops what they're doing. Her front automatically calls like her next 2 or 3 patients to reschedule. And then they start the whole protocol. And
that's great.
Each person has their own role in the Code Blanche, like the hospital, because I think she said like a lot of her employees came from the ICU or the ER. So they're just
how their brains work.
It's how their brains work.
Yep.
So that's kind of cool.
No, I actually love that, because that one time I've had a few occlusions in my time, and all were resolved. No issues, no scars, nothing. Yeah. But the one time I thought I had one with skin weave, because I had done the lips, I did her chin, and then I finished with skin weave in the whole area. And I think I just aggravated. I think it was like a spasm rather than an actual occlusion. But I've talked about this on previous episodes. Yeah. But I came out of the room and I said to my assistant, I'm like, I think I have an occlusion in there. And the patient heard me say that out in the hallway. You think you're being quiet, but you're never being quiet. And when my assistant went back in the room to just give her a heat pack to hold on to it, and she did a little bit of massage to the area, the patient said to her, she's like, oh my God, do I have an occlusion? Like I heard her say it. And she was like, no, oh my gosh, no, we're just making sure that, it's, we're just taking a look at it. But it's like, if you have Code Blanche, you're not going to make them panic,
Right.
Yeah. Like using a different term so that your patient doesn't panic.
Yeah. Right.
So I want to actually too, just a little bonus for some people, talk about what's on my crash cart.
Yep. Great.
So definitely aspirin. I give that to anyone that I think may potentially have an issue. And we do it for a couple of days. If I'm seeing them back, it's something that they're going to take for a few days. The nitrobid or the nitropase, like you talked about, prednisone, because prednisone can be great if they're also having a lot of inflammation. It can bring that inflammation down.
Or allergic reaction.
2% Lido without epi. That can be really good just for comfort. Or if you're having to give a lot of Hylenex, you can mix it into the Hylenex.
Yep.
Normal saline, the same thing, just to dilute if you need to dilute. And then also normal saline is really good if you used a Kaha product. So like a Radiesse or something like that. Yeah. There are components of those products that are hyaluronic acid, but it's not fully hyaluronic acid. So there is evidence showing if you just flood it with saline, it may help dilute it and move the product along. Timolol drops for the eyes, that reduces intraocular pressure. So I do have that in my crash cart. God forbid if someone is experiencing blurriness or blindness, you want to throw those in the eye. Viagra, we've talked about this before.
Oh yeah.
Yep. It induces vasodilation, and Viagra is actually a really important one. Not only if you're suspecting necrosis, but also if you're suspecting any kind of ocular vision changes, because it helps vasodilate the little tiny vessels in the eye. Antihistamines, that increases permeability. So it helps the vessels be able to take Hylenex. And then this, I'm going to butcher the name of this one, but this is a good one for the eyes too. Acetazolamide.
Okay.
Maybe I said it right.
I think you said it right. Yeah.
But so that's, it causes higher oxygen concentration in the body. So that's going to help with the permeability and the pressure as well. And the list goes on and on. Obviously, Hylenex is on there. EpiPens is on there. But I've just felt like those are some that people might not really know about. And then obviously wound care. I also have a rebreather bag, because that's really important if you're having an ocular issue as well. The rebreather can help. Whatever it puts, is it carbon dioxide? It helps reduce
carbon dioxide.
It helps again reduce ocular pressure.
Okay.
Yeah. So if
I think they talked about that at the Train the Trainer or something.
Yeah. It's if you just have them breathe in and out of a paper bag.
Yeah.
That can help too. And then obviously I have hyperbaric chamber, retina specialists, all those people to refer out to, God forbid, wound care, all of that. So
yeah, definitely know, like, even if it's not like a vascular occlusion, just someone who has, like, if you have lasers, someone who just has a bad burn or something like that, you can always refer them to a local hyperbaric oxygen chamber like office, which is great. So know that, have an ophthalmologist, and yeah.
And always, if you suspect anything, always call your rep. Because especially Allergan, they have MSLs, this medical science liaison. You can call them and be like, this is what's going on. If they can't help you, there are doctors and nurse practitioners and physician assistants that they actually keep on staff that they can just hook you up on a phone call. You could FaceTime. If they're in your area, some of them might even come to you. But some of them are even facial oculoplastic surgeons. So if you're really thinking you have a major issue, get right on the phone with your rep. They'll get you in touch, and then they'll get you in touch with somebody like that.
Yeah. And they're great for like your off-label questions too. Stuff that your BDM, you can't answer,
Yep. Absolutely.
Great.
Well, good.
I love it. This was a great episode.
Yes.
I hope you guys enjoyed this. This is very educational and love it.
Yeah. Thanks for listening, guys.
And if you're listening and you haven't done a cadaver course, do a cadaver.
Yes.
Okay. Definitely do it. It's so useful. And every face is different. So it's really nice to know your underlying anatomy.
Yep.
So you know that you're injecting safely and efficaciously.
Right.
So
yeah, we try to do one at least every year. And it's funny, every time you do it, you see something different.
You see something different and you learn something different and like something else absorbs into your brain because it's just a lot. Like after you do your first, you're going to be like, oh yeah. It's just overwhelming. How do I memorize everything?
Right. And then it's so funny that it's just like the back of your hand. Like, yep. After your fourth or fifth cadaver, you're like, okay.
Yes. So funny. All right. Well, thank you guys for tuning in to this week's episode of the Fill Me In podcast. We hope you enjoyed it. Till next time.
Bye.
Bye.